It's my pleasure to introduce Dr. Carmen Loisel, who I've known for quite a long time, and it's such a pleasure to have her present today. And she'll be presenting along with Samar Atala. Oh, sorry, how do you pronounce your last name?
Atiye.
Atiye. Okay, thank you. Sorry, I should have asked you beforehand.
That's fine.
So Samara Atiye and Dr. Loisel, and they will be presenting on, the title is Addressing Psychosocial Oncology Needs in a Pandemic, the Promise of Digital Health for Clinical and Research Purposes. So I think we can all benefit from this presentation, and I will switch it over to you. I'll give you control now, and we'll have some discussion at the end, okay? Thank you.
Sounds great. So welcome everyone, and thank you for joining us, and thank you for the invitation. So what we'll be presenting today is it's a field that's moving very rapidly. You'll see from the slides that there's tremendous amount of publications in the field, and keeping abreast all of this is a real challenge. But we see this presentation as an introduction to discussion, and hopefully we'll have time to do that at the end of the presentation. So we're going to talk broadly about the impact of the pandemic on cancer-related outcomes and on cancer care. What are the needs and the challenges for the healthcare systems, but also for individuals that are facing cancer and the pandemic at the same time. And we'll talk about some of the changes that have had to be made with cancer research in the context of the pandemic. So let's look at some big data on what is the impact. So there was a very large survey that was done across 54 countries and over 300 cancer centers. And what they reported, the oncologists were asked to report on this, is obviously there were a lot of cancer care disruptions. 88% of the centers reported disruptions. There was also nearly half reported that at least one chemotherapy or treatment cycle was missed by more than 10% of patients. And a large percentage, 77.5%, implemented virtual clinics, and 84% moved to virtual tumor boards. So if we look at the impact of those delays, as you see on this slide, many of the risks increase significantly with the number of weeks that the treatment is delayed. So just to give you an example, if, for instance, the treatment is delayed by 12 weeks for breast cancer surgery, there's a 26% increase in mortality. So we can really appreciate the delays are significant for many cancer diagnoses. So if we look at Canada, we have not been spared, as we all know. So, there's been lack of continuity in cancer care. There were a lot of cancellations, not only cancellations related to screening, treatment, and follow-up, but patients were really scared of coming to clinics to be screened for cancer. So many of them are just postponing even being screened for cancer. And there's more and more reports now of the danger of not screening for cancer, but they are afraid that they will go and get screened and then get COVID. So many patients have symptoms right now, and they're not getting screened for cancer. So late stages might show up in a few months. There's also been a lot of triage and treatment plan issues that have been changed. To give you a concrete example, someone with colorectal cancer that might have been scheduled for surgery has had his surgery canceled, and then they decided to put him on oral chemo while waiting to have a date for the surgery. So even if the treatment plan was very well laid out to start with, they had been to be modified and new treatment modalities included in people's trajectory. So we've all moved quickly, and I'll show data on how we've moved very quickly from face-to-face consultations to telemedicine or virtual care. And governments have been also very quick at reimbursing virtual consultations with doctors. That has always been a big issue for years. How were medical consultation going to be reimbursed? And now with the virtual access and the need for it, there was a very quick move towards reimbursing professional virtual consultation. One other thing that we've seen is much less clinical trials. So they were temporary closures or postponing for a later date enrollment in clinical trials. So if we look at cancer care disruptions, there have been studies in Canada looking at over 900 patients with cancer, caregivers, and those that were in pre-diagnosis phase, so in screening, and 54% reported canceled, postponed, or rescheduled appointments. In Quebec, there was the Coalition Priorité Cancer did a quick survey twice and surveyed over 500 patients and found that 61% reported lack of continuity in care, and 59% had reported having access to remote consultations. So if we look at, this is a paper we published last year that basically what we did is we underscore that if we're going to capture the patient experience with cancer or with any illness, we have to be very clear what are those components that we're looking at. And here I have a definition, what is the patient experience, but also what is the patient perspective on that experience. So another component, which is the family or significant other perspective, which often is different from that shared perspective. So we need to really take into account that experience. And obviously there's the experience with the healthcare system, so all the interactions. So if we look at these four components of the patient experience with illness, we realize that it has been really complexified greatly by the pandemic, because even last year when we were studying these different components, it was always in relation to cancer. But now we have to look at the patient experience with cancer with a superimposed threat or potential threat or actual experience with COVID. So that really rendered this whole patient experience very complex, because as if we think about the patient experience with cancer, all of a sudden either they also diagnosed with COVID, or they're afraid they're going to get COVID. And then how does that affect their experience with sharing with significant others, because there's again the fear of contagion, and then the interaction with the healthcare system. So these components have been completely challenged now, and it's really going to be important to document people's experience with this new reality. So when we look at COVID-19 and mental health issues in general, what the research is showing is that 1 in 5 that has been diagnosed with COVID also report mental health issues, which includes anxiety, depression, insomnia, and this is within 3 months of testing positive. So if you look at the survivor of COVID in this graph, you see that 20% basically are affected by mental health issues. If we look at COVID-19, cancer, and mental health, 74% in Canada report an impact on mental health, so a significant impact on their mental health. And in Quebec, 67% report anxiety or worsening of existing mental health problems as they're dealing both with COVID and with cancer. So some of the issues with their interaction with healthcare is with the prioritization of COVID-19, they feel that there's reduced attention to other illnesses, that COVID has rendered it so salient that everything else is sort of taking a back seat, and they're worried about it. So there's also unmet needs that we're very well aware of is, patients are worrying about their health, but they're also worrying about their finances. And they're worried that what was really promoted for instance, exercise and cancer-related outcomes, now they have a significant reduced activities because many of those wellness centers are closed. So what was really benefiting them now is also in jeopardy. If we look at COVID-19 and cancer and its impact on anxiety, you see that when we ask patients, is the pandemic causing you more anxiety than usual? 65% say yes. And this was a survey conducted in Quebec. So what are some of the things that people are worried about? And this is from Marie-Pascale Pomera, who did this survey. And so some patients are saying, my surgery has been postponed for 5 months. What is that going to do to my health? My follow-up MRI appointment was rescheduled for an unknown date. I can't make my follow-up appointments. I'm too afraid to catch it. My psychology follow-ups are fewer despite my great need, especially in these times of pandemic. Yes, it's done over the phone, but there's no physical exam, which is very important. My greatest need, especially during this period, is well-being. Cancer wellness centers are closed. So these are some of the worries. So if we look also, if we go back to the 4-component model, I was talking about the importance of capturing the patient experience in interaction with significant others. Well, when we ask patients, during the last 2 weeks, my caregivers have continued to be physically present with me. 38%, but that was a couple of months ago, right? So this has changed because the rules have changed, but nearly 40% said yes. Only 13% said no, but what's interesting here is 40% say it's not applicable. Not applicable means that these people probably don't have a caregiver, so they could be considered vulnerable. So we're looking at over half of the population that was asked about the caregiving. Over half are saying, well, I don't have a caregiver, or no, I haven't been able to have someone physically present with me. And my feeling is that if we were to redo this survey, the yes would go down significantly. When we ask patients, what are some of the services that should be put in place to help them cope better with cancer through the pandemic? The top request was that they would like to have regular follow-up updates by phone or email with the medical or the psychosocial team. So it seems that patients are that both medical and psychosocial input is really important in this time of the pandemic. So now we're going to talk about remote care. And, you know, there's different terms: virtual care, remote care, health, communication. But we'll just use remote and digital in this presentation. So what are the key components of remote care? The first thing, obviously, is we want impact. You know, so remote care should be filling the gaps in care and ensure that we reach as broadly as possible people that need the care the most. So it has to be inclusive. The second component is has to be very practical. So what are the most promising cancer care solutions? Well, they have to be cheap, they have to be relatively low tech, and they have to meet with the realistic resources that are in place and how it can be executed, because it's not everyone that has sophisticated equipment. So if you can reach, you know, a healthcare provider by phone or by your digital means, simply, that's usually what really works well. And then scalability. So those remote solutions should have a lot of potential for uptake that is incremental, meaning you start low tech and you keep moving up that incremental uptake. So you can, those solutions that can be scalable are very promising. Replication means that, you know, those solutions should be transferable with minimum adaptation. So this is where I'll bring some recommendations to make sure that this is replicable. And obviously those solutions should be innovative. They should create breakthroughs that really optimize psychosocial oncology processes and outcomes. So what kinds of support and what does that look like? Well, those solutions have really favored interaction not only with the healthcare team, but also among patients. So more and more we're seeing support groups that are popping up with remote care. As I said earlier, we need access to those remote care modalities that are low and high tech. So low tech would be the phone. Some older patients say, give me the phone, I don't need to do Zoom. And other people say, I want Zoom, I want interaction that I see facial expression. So we have to be sensitive to people's preferences. And there's been a lot of different tools for remote consultation. I've just listed a few here. And so what is important is that we need to maximize access. It has to happen when people need it the most, and it has to be high quality. So when we ask patients, since the start of the containment measure, have you received or been offered a remote professional consultation? 77% in Quebec said yes, 18% said no, and some said it was not applicable. And again, this was done a couple of months ago. If you were to ask again, we probably would see even higher percentage of people that have been offered a remote professional consultation. So if we shift from remote consultation in cancer care in general to psychosocial oncology in COVID, so what we know from the literature is that there's a decrease in patients referred to psychosocial oncology services as we speak. It's either delivered remotely or it's suspended entirely. And there are some challenges with remote psychosocial support delivery, and we'll talk about that. So what are the strengths of having psychosocial oncology support through remote means? Well, we can access a lot more people. We could have a multidisciplinary team involved. It's reduced costs, and the research shows that there's reduced cancellations of appointments. Some of the challenges is that little evidence on their effect compared to other means of supporting patients. And we have variable access to technology, especially for vulnerable groups. Psychosocial oncology professionals have limited training. We all have to really had to learn a lot of different means of interacting, and the learning curve has been steep. The other issue that keeps coming up is privacy. So which platforms are more secure? How patients, do they worry about the privacy of the information they're exchanging online or through Zoom calls? So that those are some of the threats or the challenges. Well, what are the opportunities with this context is that we can be very creative and develop more different apps for different needs. We reach out to more patients. We can create new internal or external networks and collaborations so that we make this care. If we think about the multidisciplinary team, we now see that through virtual means, different professionals can get together and have consultations with patients very easily. Some of the threats that we're experiencing is that psychosocial oncology is often not prioritized because we're really going for, okay, what are the acute needs right now? What can reduce morbidity, mortality, and how can we best mobilize these support systems? We're also worried that maybe with all the new technology that there may be risk of cuts and funding to psychosocial oncology programs. There might be also, because patients are saying that they really need that support, there might be a great influx of new patients, and how do we deal with this? And then there's, staff being overwhelmed by the demand and burnout. So if we look at the quality assessment of these tools, I think that we have to look at, as I said earlier, the experience of patients with it. So how do frail patients deal with the technology? How comfortable are they with this? What about delicate conversations? How is that happening? How with delicate conversations? I've mentioned the access to care. the effectiveness, we need more knowledge on patient knowledge, behavior and outcomes, patient safety, and I've talked about the other issues. Cost and financial aspects are also very important. So how effective is this? How much resources are we using? And often hidden are the out-of-pocket costs for patients. So do they have to get more technology in their household? Do they need to be paying for, you know, more broadband to make sure that they can access all the support in all these different means and have enough gigabyte to deal with this, and that comes from out of their pocket. So I just wanted you to be aware, maybe some of you are already aware of the Canadian Virtual Care Task Force that was established in 2020. So just here, why is it important? Because, you know, this group is looking at overcoming barriers in remote care, so new fee schedules, simpler health professional licensing, early integration into training, because we're training new professionals, and how do we integrate these new technology within that, and developing national standards for virtual care. So one thing that they're really promoting is an agile system that quickly respond to societal and health-related changes. Obviously, the pandemic has challenged that system greatly, and it's how agile is remote care to address that. So one of the aspects that's very important for regulation when we talk about remote care is patient centricity. And what that means is, how are these remote care solutions developed so that they really take into consideration patient needs and preferences? So they're recommending several things to increase patient centricity. The first one is patient engagement in all these advisory committees, because we'd be surprised how many times patients are left out. They should be also actively involved and welcome to contribute to design, and be empowered to use these tracking devices data and push for inexpensive wearables. So if we have a choice, we should really think of patient and cost and push for things that are affordable. We should also talk about how accessible these things are, and how documenting how this enhances patient healthcare provider communication, but also communication across patients. I'll give you an example. With those remote support groups, one thing that we've noticed in palliative and end of life is that when it was the typical face-to-face support groups, when people got sicker, they did not come to these groups anymore because they couldn't travel, they couldn't sit. But what the observations that are happening now is that communication link is constant, and people that are even in late stages towards end of life care, they still join those support groups because it's easier, and they can get the support and the interaction that they wouldn't get if they were isolated because they can't travel. So patients are now exposed to their colleagues or to their other patients that are entering late stage of disease, and they're still in contact with them up until the end, which is very important, again, to document what impact it has, not only on the quality of that end of life phase, but also the well-being of those that are participating in the support groups. And patients been asking forever to have ready access to medical records, test results. And they also stress the notion that they want to co-participate in care decisions. And how is remote care facilitating this co-participation in decision-making? So now I'm going to turn over to my doctoral student, Samara Attier, who will talk about the impact of COVID on research.
Thank you, Dr. Loisel. So as we saw with you, the COVID-19 pandemic has had a profound impact on every aspect of cancer care. This pandemic also affected research. So last March, the federal government invested around $275 million to fund COVID-19 research. and we saw a surge in COVID-19 studies. There are actually now more than 4,200 studies listed in the clinical trial platform, and another 3,100 listed on the clinical trial platform that is affiliated with the World Health Organization. If you look also at Prospero, you can see more than 2,800 systematic review related to COVID-19. Also, if you want more specifically with cancer, you can quickly run a quick search on Medline Ovid, and you can find more than 3,300 studies on cancer and COVID-19. This pandemic also affected how research is and should be conducted. Safety consideration that were not needed before are now essential to conduct research safely. So therefore, the institutional review boards developed some new guidelines to prioritize participants' safety. For example, in-person research activities have been postponed. Many researchers had to submit multiple amendments for their ongoing studies to ensure participant safety without also compromising their study integrity. Many new submissions also have been delayed because COVID-19 related studies have been given a priority and expedited review processes. As a doctoral candidate myself, I had to go through this delay. I was preparing my proposal and wanted to submit it last summer, and I experienced a delay, although my proposal on interprofessional collaboration, I feel it's equally important in these challenging times. So I also had to adjust my methods in my proposal, in particular the recruitment strategy, as well as the data collection, as per the revised ethics guidelines that highly recommend now remote recruitment and online data collection. So speaking of online data collection, there are a range of tools that can be used. I gathered here in this slide the most popular tools used for quantitative and qualitative data collection. For quantitative, we have Qualtrics, RADCAP, and Lime Survey. You can also embed open-ended questions within these platforms. For SurveyMonkey, it was pretty popular before, but now it's no longer accepted by ethics because it's strongly discouraged because it often fails the security needs. For qualitative, we have the most popular are Zoom Premium, Microsoft Teams, and WebEx. So as for the benefits and challenges of remote data collection, it carries the potential of accessing a large and geographically distributed population, along with being time and cost efficient for researchers. It can avoid hours of data entry because it's done automatically while entering the data, while responding to surveys especially. You can also, it has the feature of streamlined data export. You can export your data anytime while the study is like ongoing or before finishing also. For the challenges, it needs a certain cost. The platforms are not all for free. You need licensing and equipments. It requires also some technical training or hand-on assistance, especially for older population, to learn, for example, how to navigate the online survey or the steps to join a teleconference or a focus group, let's say. Another important challenge is the security of the tool. Researchers need really to consider choosing platforms that protects participants' privacy with no third-party data tracking. So the gold standard in quantitative tools now is Qualtrics. It's a secured web-based electronic system. It's not just for data collection, but also for management, and it's a storage system. It's data is stored on protected Canadian servers. It's monitored and audited for compliance. You could embed e-consent forms, surveys, self-reported questionnaires. You can even assign unique IDs for participants to increase confidentiality. And also you can randomize. It has a feature also of automatic data backup and recovery. And one of the most interesting features in Qualtrics that interests researchers and even students is the 24/7 technical support, because you can reach them by phone, email, and chat in real time. They have offices globally, and they can also log into your project online in real time and review solution with you if needed. Otherwise, they can create also quick videos on how to implement complex features. Back to you, Dr. Loisel, to discuss future directions.
Thank you. Very nice overview of how we had to shift as researchers quickly. Just to talk, and this might spur some conversation because we wanted to leave time for discussion with participants, but I think that the future directions will focus on rethink promising cancer supportive care modalities. So it really has jump-started us to think about what are those modalities that hold promise. We're also really pushed to think about those concepts that have been floating around for a while, but now really need more attention. One of them being value-based healthcare. What does that mean? You know, in times where a lot of things will be done remotely, and cancer care pathways. So do we need to be working much more on typical cancer care pathways to make sure that people don't fall through the cracks because there isn't that as much of that continuity of care. So I think those two concepts are really important to address in time of pandemic. We should continue, if people are involved, to do comparative studies on remote care solutions. And when we're doing comparative studies, we need to be getting the perspective of all stakeholders, patients, significant others, healthcare providers. And one thing that's been, you know, really a challenge is to foster more of a climate of collaboration in, you know, many of those private companies who are developing those healthcare solutions remotely have been running with it on their own. And now the times are such that there should be much more collaboration across those companies so that we improve, you know, different, like an overall global remote care solution rather than have competing ones. So that was the last point I wanted to make, which I think we are seeing much more in the past, I would say in the past few months, much more collaboration across companies to say, okay, let's see what we do really well. Let's see where we're not so specialized, and let's partner with other companies that are specialized. And so I think it's very promising to see that collaboration rather than the competition. So now we'd like to move to an open discussion with participants. You know, if you've been a clinician or a researcher, what have been your own challenges right now when it comes to psychosocial oncology or clinical care? Have you really endorsed some solution that worked really well? Do you feel that the resources are available for what you want to do? And do you want to share with us what you've learned also? Because it is a field that's changing so quickly.
Thank you both so much for such a comprehensive presentation that, you know, provides a wonderful overview of the impact of COVID on both clinical and research. I think that was really helpful, and I'm sure that there's going to be lots of questions and comments. So I'll open it up to people. If anybody has a comment, please just unmute yourself and go ahead.